Good evening, everybody. Good afternoon. My name is Shiv Bhandari. I'm one of the chief residents at University of Washington Medical Center. And thank you for coming to our very first Grand Rounds for the academic year. For those of you who haven't attended Grand Rounds before, just briefly, Grand Rounds is a conference occurring every 2 weeks. We're focused on building community across all of our hospitals and across other institutions as well. We hear the latest in science and medicine from experts, and the goal of ultimately sparking curiosity to learn more and become better providers. So with that, again, thank you for your attendance today. I'm very excited for our speaker. I'd like to introduce Dr. Leo Morales next. He is a professor of medicine at the University of Washington, as well as an adjunctive professor in the Department of Social Work, Health Systems, and Population Health, and then also an assistant dean at UW Medicine. And without further ado, I'll pass it on to you, Dr. Morales.
All right. Thank you very much, Shiv. Thanks for that introduction. Yes, welcome everyone. It's great to be here. And today's talk is going to be given by a very special person, a friend and colleague from UCLA. Before I start, I want to acknowledge that this Grand Rounds is being sponsored by the Office for Healthcare Equity and the Jedi Center. So Dr. Donna Washington is the director of the Health Equity Quality Enhancement Research Initiative, or QUERI, National Partnered Evaluation Center for the Veterans Health Administration. This center is part of a system-wide transformation that is utilizing embedded partnered research methods, tools, and rigorous evaluation to improve veterans' health and healthcare. Dr. Washington is also the Associate Director for Health Equity Research at the VA Health Services Research and Development Center, HSR&D, for the Healthcare Initiative Implementation and Policy, and Director of Health Services for Research at the VA Greater Los Angeles Department of Medicine, and a professor at UCLA. She's a general medicine, internal medicine physician. Her research has focused on healthcare needs of marginalized and underserved populations, particularly women, racial, ethnic, minoritized, and low socioeconomic status veterans. Over the course of her career, Dr. Washington has worked to advance research methods so that the VA can better discern what multi-level factors drive racial ethnic disparities in quality and mortality by integrating residential characteristics such as poverty and other organizational factors into models capable of identifying the variations that actually occur. Her approaches demonstrate how social determinants of health best models are how social determinants of health among racial, ethnic, minoritized veteran groups can undermine even our best healthcare models. Dr. Washington's research has led to national VA policy to address delivery of services for women and has contributed to the VA's strategic plan for improving health equity. Dr. Washington has received numerous awards for her work, including the Society for General Internal Medicine's Herbert Nickens Award, the Congressional Black Caucus Veterans Brain Trust Award, and the 2020 Undersecretary's Award for Outstanding Achievement in Health Services Research, which is the highest honor for a health services researcher in the VA. So Donna and I met when we were in residence at UCSF in primary care, and then we followed each other to UCLA, and it's really great to welcome her here to Seattle. So with that, Donna, let me get your slides up here for you. Here you go.
Thank you so much for that kind introduction. It really is an honor to be here to help kick off Grand Rounds for this academic year. I'll be discussing health equity in the VA, lessons learned from a learning healthcare system. So I have no disclosures, no financial or other conflicts of interest, nor do the planners of this talk. And it's really important for me to emphasize that the views presented do not represent that the views expressed are my own and do not necessarily represent those of the Veterans Health Administration or the U.S. government. I'm just going to back one slide so that when the slides weren't shared, you can see that the topic is health equity in the VA, lessons learned from a learning healthcare system. So the learning objectives for this talk today are threefold. Number one, describe characteristics of the VA healthcare users and VA health disparities in VA. And that's really a key objective so that you understand how it's a great model for really understanding health equity and acting on it. Number two, I'll discuss, and at the end of this talk, you'll be able to identify underlying contributors to health. And then number three, understand actions healthcare providers as well as health systems can take to promote health equity. So it's important for all of us to be on the same page when we think about what a health disparity is. I like the Healthy People 2020 definition. There are many, but this one really captures some of the essence of what matters. So health disparities are a type of health difference that is closely linked with social, economic, and or environmental disadvantage. And it adversely affects groups of people who have systematically experienced greater obstacles to health based on characteristics such as race, ethnicity, socioeconomic status, gender, and others that are historically linked to discrimination or exclusion. What I really like about this definition are two things. Number one, in the second part, it talks about groups of people. And so often when we measure equity or gaps in equity, we may be measuring it by groups of people, but it really isn't the race of the person. It's not the ethnicity. It's not the sex. That's not really what's leading to adverse outcomes. It's the upstream factors. And it's these socio-economic and environmental disadvantages. That's, if you take away nothing from this talk, take away that, because that's telling us where to act. So some may say, well, health disparities aren't necessarily relevant for me. They're it's something for other populations, other areas, and so forth. We're here in Seattle. I wanted you to know that relevance of health disparities are depicted pretty nicely by this map. It shows that they're just a short drive away in your very own backyard. So this graphic shows the average lifespan of, this one shows males, the next slide is females in King County. And this is a snapshot of the average lifespan in 2014. It's a neighborhood study at the census tract level. And it shows that like 20, 25 minutes away in Auburn, life expectancy is 18 years less than it is up here in Seattle where we sit. When you look at the map for women, it's 14 years. And so there are huge gaps, even in this county, which has one of the highest life expectancies in the country. So it's relevant for us, it's relevant for the patients that we serve, it's relevant for our research subjects, it's relevant for the population around us. And it's important to know that, because if we don't look for it, then we may not necessarily understand some of the obstacles and contributors to outcomes in the patients that we serve. Some of the unique aspects of VA healthcare that are important to note are, one, that it has not just a healthcare, but also a social mission. It's the largest integrated healthcare system in this country, providing comprehensive primary, mental health, social, and other services. And what's really nice about studying and actually acting on health disparities in this setting is that it eliminates insurance and some of the major financial contributors to disparities. And so it really allows us to, number one, take addressing health equity to the next level, but also it opens up sort of the box of understanding what some of the drivers are beyond sort of the big elephant in the room, which is lack of access due to insurance and finances. The VA patient population is older, sicker, and poorer than veterans in the US population. It's a diverse population from a racial and ethnic perspective, with 27% of the population identifying with a minoritized group. It also has a very large rural population and an increasing female cohort. So when we think about income, this map of the United States shows VA enrollees with incomes less than $35,000 by region. VISN is the Veterans Integrated Service Network. Those are the regions across which the country is divided. So it's trying to use the cursor, but I can't find it. So I'll just say that if you draw your attention to the top left corner, the Pacific Northwest, where we're at, that's VISN 20. In VISN 20, 36% of VA enrollees have incomes of $35,000 or less. And just for context, the federal poverty limit in the year this data reflects for a family of four was $26,500. So these are people on average with less than 200% of the federal poverty limit. Thinking about racial and ethnic distribution, these bar plots show the racial ethnic distribution by sex among veteran VA users. And this is for fiscal year 2020, so October 2019 to October 2019 to September 2020. And looking first on the left, that's the bar plot for women veterans. You can see that it is quite a racially diverse population. 42% of women identify with a racial ethnic minoritized group. That's much greater than for male veterans. In general, women veterans are younger. They've served more recently, and it's really showing sort of the future of where the VA population, but also the country is heading. That's depicted nicely on this slide, which shows the projected growth in the racial ethnic minoritized veteran population over time. And so you can see, for example, the blue line on top, non-Hispanic Black veterans, that is growing, that population is growing by about 150% through the year 2040. Hispanic veterans, it's even a steeper upcline in terms of the percent representation. And so we're looking at a majority minority population. Understanding disparities is not just relevant for a minority, it's just taking on increasing relevance for all of our patients over time. What I'm showing you is the VA, but it really is absolutely true for the rest of the country. So before I shift to talking about some of the racial and ethnic and socioeconomic status related disparities within the VA, which is really, I should have started out by saying the two areas I'll focus on with equity issues today, then I want to just set the context for understanding VA quality. There have been a number of studies, there have been several systematic reviews that have compared the quality of care in the VA with the broader US healthcare system. So what's depicted is a VA versus non-VA quality of care systematic review that was just updated in April 2023. This includes many studies such as the landmark trial in 2004 that looked at health plans across the country on a number of different broad quality metrics. And the bottom line is that VA patients received higher quality care across broad measures. This is reaffirmed in systematic reviews, first in 2010 or 11, then in 2023. This included clinical quality of care, safety, and surgical care. These differences were greatest in areas where VA has established performance measures and actively monitors performance. So that's one of the key lessons learned. Number one, if you look at it and measure it, then you'll understand where the gaps are, and then set up processes for addressing it, and the performance will follow. So that's an important backdrop. So though I'll focus on the equity issues, it's really taking it to the next level. It's saying, okay, we've achieved great quality care for the broad population. Let's look within at variations in care so that we assure that some of the quality advances apply across all populations of patients. Health equity in VA healthcare has been summarized in many different ways. The Office of Health Equity has published a series of reports. The most recent national report is the National Veteran Health Equity Report. This is patterned after AHRQ's National Healthcare Quality and Disparities Report. And so it's drilling down into the VA healthcare system, looking at broad measures of patient experiences as well as healthcare quality. This particular report brings together 4 years of data, 4 years as one of the strategies to amass sufficient data to look at some of the understudied smaller populations that are ignored in sort of the broader scientific literature, not just in VA, but in general, because the numbers just aren't there. So this is a strategy to really understand where the gaps are across the whole population for sociodemographic characteristics such as race and ethnicity, selected health conditions, and many other type metrics. And one of the points I want to make from this slide is that for those who are researchers in the room, it's not sufficient to just do the work and publish it, but really one way to enact change and really address health equity is to disseminate this work in a form that's publicly accessible to all audiences. It's getting some of the information into the hands of the communities that are affected, as well as policymakers and others. And so this is sort of one avenue, this series of reports for achieving that. Some of the findings from this report are depicted on the next few slides. And so let me orient you to the slide. These are what are called 100% stacked bar charts. And so what we did was we looked at several different domains of measures. This particular slide shows the domain of person-centered care. It's the experience of patients. So for example, their interactions with clerks and other people, frontline people as they access healthcare. It's experiences in the clinician provider relationship. It's those aspects of care. And so this particular domain has 16 measures. Those are the small numbers in each of the bars. And what we did was to define what a meaningful difference is. So these are nationwide surveys of patient experiences administered to a representative sample of patients each month actually compiled sort of annually. And what we did to really synthesize it in a way that easily shows where some of the gaps in care are to define meaningful differences. So they're both statistically significant differences for each measure, as well as a clinically meaningful effect. Because some of our numbers are very large, we may identify small differences that may not matter, but we wanted to focus in on ones that were large enough and statistically significant that they really do present clear signals for where to act. And so those are color-coded in red, measures in which there are clinically meaningful differences that are disadvantaging the population. Yellow, they're equivalent. Green, the potentially marginalized or at-risk group does better. And so this shows, on this particular slide, we're looking at veteran groups that are lower socioeconomic status based on threshold that combines sort of geographically based and family size adjusted annual income. And so it's looking at low SES veterans by that metric compared with higher SES veterans. And this is age stratified because so much of patient experience as well as outcomes is related to age. So what you see is a very large swath of red across all three bars, meaning that there are some many gaps in care for veterans of lower socioeconomic status. As I mentioned a few slides earlier, this, I'm not showing a direct comparison with what you see outside the VA and the larger healthcare system, but this is really sort of a microcosm of what's reflected in the broader healthcare system. So this is just drilling down to one of the measures. This is providers showing respect. So for veterans of lower socioeconomic status, comparing with higher socioeconomic status in the last 6 months, how often did their provider always show respect for what they had to say? The red bars on the left show that it's a meaningfully lower proportion for low SES compared with the gray bars, which are the proportion for higher SES groups. So I've oriented you to the slide. This shows the same sort of summary metrics by race and ethnicity. And so this happens to just focus in on veterans who are age 65 plus. It's looking at patient-centered care by veteran race and ethnicity. And what you can see is that for looking across each of the groups, that there's that it's not a monolithic sort of minority, quote unquote, versus non-minority experience, but rather each minoritized population has unique experiences. And so it's there are greater decrements in care for some groups. American Indian Alaska Natives are the second bar. So you can see actually for 8 of the 16 measures, or 50% of the measures, there were clinically meaningful gaps. For Asian Asian American veterans, it was 7 out of 16. So really large gaps in care for those groups, but some gaps in care for all groups. Shifting to clinical preventive services. So this would be services such as receipt of an influenza vaccination, receipt of a pneumococcal vaccination. It would be getting age and gender appropriate cancer screening. And this is just showing the comparisons by socioeconomic status and age for each of those. And so sort of the largest gaps were present for those age 65 plus, but there were also some meaningful gaps in younger age groups. This is just one example. This is whether influenza immunization was accepted. There's another slide, I don't think I have it in here, about whether it was actually received, which gets into more going beyond sort of acceptance to other care coordination aspects. But anyway, it's showing that for the oldest and youngest age groups, there were gaps. I mean, overall, the numbers are actually higher than some of the thresholds you see in other areas, but it's not the much higher level that would be great. So this is now looking at clinical preventive services, sort of summarizing the number of measures for clinical preventive services comparisons, and this is for the 65 plus age group. Couple of things I want to highlight on this. For some groups, then the bulk of the comparisons showed equivalent or even better care. So for example, for individuals who identify with more than one race, then there weren't any gaps in care. For Native Hawaiian and the Pacific Islanders, that's the group on the far right. For Hispanic or Latino veterans, the group on the far left, then most care was equivalent. But there are large gaps for some groups, for African American or Black veterans and American and Alaska Native veterans. I'll shift now to talking about health outcomes. And so one of the things that I want to mention is that this is the start of several slides that you'll see based on the county health rankings and roadmaps framework, which is a really nice framework for understanding the drivers of health outcomes. The example I'll give relates to length of life, but this framework really highlights also the importance of quality of life. And so when you think about what matters to patients, it's not only how long you live, but how well you live. So I'll just talk about one study related to mortality, and that's looking at racial and ethnic disparities in mortality, not only across the VA healthcare system, but then in comparison with the broader US population. So we characterize disparities in all-cause cancer and heart disease mortality within the VA, and we compared those mortality disparities among veterans receiving care elsewhere. Let me see if I can get rid of that. Great. So, okay, so some of the methods I'll just go through fairly quickly. We took advantage of the large electronic health record system with detailed links to the National Death Index and patient characteristics to get our data. We conducted Cox proportional hazards regression. The results I'm presenting are sex stratified and age standardized mortality risk ratios. And we looked at non-overlapping confidence intervals as a way of detecting statistical significance for this particular set of analyses. So this shows mortality disparities comparing VA patients and the US general population. The way to look at this is the age standardized mortality ratios. If they were equivalent, they would be exactly crossing that horizontal line of 1 in the middle. So actually you can see American Indian Alaska Natives in the US population are there, whereas some of the point estimates are above that line. So those are areas of disparities, and those below the line are areas where there's a mortality advantage. So first, looking at American Indian Alaska Natives, the black bar on the left shows that actually there are higher disparities within the VA compared with the general US population. Second point I want to make is that for Black veterans, there are actually disparities in both settings. For veterans within the VA, that's the blue colored point estimate on the left, the disparities are lower than those in the broader US population, which is the green estimate on the right. Adding cancer and heart disease comparisons, it's the same sort of setup. Then you can see that the same gaps that we saw in all-cause mortality for American Indian Alaska Natives are also present for cancer mortality. So this shows mortality disparities for women in the VA and the US general populations. Same setup, it's showing all-cause mortality in the first panel, cancer mortality in the middle, heart disease on the far right. And I'm going to draw your attention to the main findings on this slide. So the main findings have to do with comparisons between the VA patient population and the US patient population for African-American women. And it's showing the green is showing both for all cause as well as the major causes of death, that there are disparities outside the VA in sort of the broader US population. Black women die at an earlier age than white women for a variety of reasons in this country. Within the VA, there's equity. There's similar mortality rates. This just sums up some of the points I made, so I'll continue. As we were conducting this work, COVID came along. And so we applied many of the methods that we had been using to examine equity issues for several different outcomes to the COVID pandemic. And one of the things I want to say is that it really caused us to conduct our research and actually conduct our evaluation in a very different way. Some of this work was done very closely with the VA's Office of Health Equity, which really sort of championed and led some of the efforts with many of the different program offices to understand what the most pressing questions were needed to bring data and research methods to the service of acting real time to affect change. That's really a lesson, is to have that embedded relationship between researchers and clinical partners so that we're using methods to provide the best information we can to answer real-time questions. One of the things we found is that unlike the pace of research where we're looking at data or compiling these detailed data sets maybe once a year and really mining them over time, we were looking every week. And what we found is that the data was changing. And so we would say one thing one week and something different perhaps the next week. And it was creating confusion until we took a step back and say, hey, the data's changing because the pandemic's changing. We're not looking at something static. We're looking at something that a widespread infection that really is changing based on geography. It's surging in different areas at different times. The policies across the country were enacted at different times and in different ways and had different levels of effectiveness. And so it really is like no mystery then, once we realized what was happening, why these data were changing. What we were interested in with this particular analysis is how that affected what we were seeing in terms of racial and ethnic disparities, and whether what we saw in the broader US population needed addressing real time early on within the VA. So we know that the US population estimates showed really early widespread disparities in both infection and mortality for Black and Hispanic groups. They didn't really say a whole lot about all of the other groups. And they certainly didn't look at change over time. And so with that, this is showing the first year of the pandemic. What pandemics have in common with earthquakes, with hurricanes, with all other big disasters, whether man-made or so-called naturally occurring, is that vulnerable populations are those at the greatest risk for adverse outcomes. And often early on, there's confusion with pandemics, with other disasters. There isn't a lot of information. And so that's when the greatest opportunity exists for prevention, if you understand what's happening in terms of who's affected. And so that's why with this particular analysis, we focused in on the first few months of the pandemic to look at how things changed. So each line represents a different racial and ethnic minoritized group. The gray line represents non-Hispanic whites. That was the comparison group for these statistical comparisons. This looks at COVID-19 mortality among COVID-19 positive VA healthcare users. And we looked at 3 different so-called seasons, so 3 months of points of time in the spring. So that's the far left. You can see that there were disparities in mortality early on for Black veterans compared with non-Hispanic white veterans. With time, 3 months later, then disparities emerged for some of the other groups. And in fact, the largest gaps were between American Indian Alaska Natives and white veterans. But there were also gaps that were emerging for Asian veterans as well as for Hispanic veterans. And then with time, with policies, with information, then mortality dropped for all groups. So what about vaccines? That was another big area early on. Then there was a shortage of vaccines. There was difficulty accessing COVID vaccines when they were first available. And once again, this is an area to think about where potentially marginalized populations may have been disadvantaged. There's many talks available on the internet and elsewhere looking at some of the underlying factors. Some of it had to do with access. If you're homeless, if you're someone who doesn't have a car, early on, if you have a drive-in vaccine administration site, you just don't have access to that. If you have a history of mistrust of the healthcare system, then with vaccines that may not have been communicated in a way, the development, then there may be mistrust about what you're actually getting. And so for a variety of reasons, then there were racial and ethnic gaps in vaccine uptake in the broader US population. So recognizing that and then being able to sort of use the data within the VA that I showed to understand where some of the gaps were, enabled VA to develop public health and other types of information campaigns early on, using dashboards to take advantage of identifying sort of who our patients were, where they were, and so forth, to really develop sort of culturally tailored information to help address some of the questions that may arise. What we found with this particular study, and this was once again very purposely timed for when there were gaps in access to really understand what was happening early on. Then what we found is that these campaigns were successful, and in fact, that Black, Hispanic, and Asian veterans were more likely than non-Hispanic white veterans within the VA to receive vaccines to the VA early on. American Indian Alaska Natives residing in some of the counties, counties that are either adjacent to or contain federally designated reservations or tribal lands, that American Indian Alaska Native veterans in those areas were less likely to receive vaccines, but those outside were equally likely. So underlying contributors to health. This is a further snapshot of the county health rankings and roadmaps, and it defines health factors in 4 broad groupings in consideration of determinants of health outcomes. So health behaviors such as tobacco use, diet, and exercise account for 30% of the health outcomes under consideration. Clinical care, access to care, quality of care account for 20%. Social and economic factors, education, employment, income, family support, and so forth, account for about 40% of the health outcomes that we see. And then the physical environment, such as air and water quality, housing, and transit, account for about 10%. There are several important points I want to make from this model. The first point is actually that social determinants of health. So when you look at the social and economic factors as well as the physical environment factors, collectively, these account for about 50% of health outcomes. We're up here in the box above, clinical care, 20%. And what this means is that when we think about how to affect positive outcomes in our patients, we really have to think about the context in which they're living their lives and putting into practice some of the recommendations that we're making so that we can tailor it, work with them to really tailor our recommendations to the context of some of these social determinants of health to better enact patients to make it more relevant in a way that they're able to put into practice some of those. So social determinants of health, using the WHO definition, are the conditions in which people are born, grow, work, live, age, and the wider set of forces and systems shaping the conditions of daily life. So some of you sitting in the audience, those of you online may be thinking, wait a second, there's some things that are missing from this model. We've been talking about race and ethnicity. We've been talking about socioeconomic status. We've been talking about veteran status and sex and gender. They're not on this model. Why is that? And the reason is that health factors are modifiable. So this model is helping us to think about where the change needs to happen to improve health outcomes. And so what race and ethnicity, which are social constructs, or some of these other characteristics tell us is that these are the groups that are disproportionately affected by some of the adverse social determinants of health. And when you think about then where to act or why to act, it's not, oh, this group has worse outcomes or this group is not coming in for care or whatever. It's really helping to understand what some of those upstream factors are that are really correlated with groups and leading to these outcomes. So this is just one example. This is actually looking at both the social determinants, the social and economic factors, as well as physical and environment. This is actually one of the recent COVID studies that we conducted, and this looked at environmental toxins and what the role of environmental toxins were to some of the racial and ethnic disparities that we measured in COVID-19 hospitalizations. And what we found is we use for environmental toxin exposures the RSCI model, which is measuring environmental indicators risk model. Black veterans were more likely to reside in census tracts with higher, actually with the highest RSCI scores. And exposure to these environmental toxins partially mediated the association of the disparities with COVID-19 hospitalizations that was independent of some of the medical comorbidities that we know increase risk. So a second major point I'd like to make from this model is that health factors are interrelated. So for example, social determinants of health influence the behaviors. Your environment, your context shapes your behavior. If you live in a safe community or have access to healthy food, it makes it much easier to adhere, for example, to recommendations for a DASH diet. Social determinants of health, for example, access-related ones, transportation, internet, broadband access, those are enablers of access to clinical care, whether it's in person or telehealth. A picture is worth 1,000 words, and this is just illustrating a lower socioeconomic status related neighborhood. So being surrounded by liquor stores, being in sort of a food desert with the absence of healthy food, having police lines and pavements where you can't take your kids to play, leading to childhood obesity. These are just some of the reality that are underlying some of these measures of social determinants of health that then drive behavior. So they're interrelated. This, by contrast, is showing a higher socioeconomic status related neighborhood, access to healthy foods, nice, safe places to walk and exercise, public transportation. So these are just a couple of examples of some of the interrelated aspects of this. So, for example, one study looked at food insufficiency in women veterans and showed that that actually impacted care access and health outcomes. Another looked at race, poverty, and mental health. It actually looked across the spectrum of the health factors and teased out which ones were linked to disparities in colorectal cancer screening, and found race, poverty, and mental health. So across the spectrum of sociodemographic characteristics as well as clinical characteristics really interplayed to create to a disadvantage in receipt of screening. And then looking further, this is another example from some of the COVID work. We really wanted to really dive deeply and understand, well, what about these social factors matter? So this study, we looked at the percent of households using census tract data without complete plumbing, the percent without kitchen plumbing, and neighborhood socioeconomic status. And we found that that mediated some of the American Indian Alaska Native code of COVID-19 disparities that we identified. In fact, 1/3 of the disparities were attributed to that. We were fortunate to be able to have a dialogue with the National Indian Health Service, who invited us to their health board to discuss some of these findings. And it really provided insight into how communities get their water and how, like feet on the ground, some of these measures really translate into some of the gaps in care that we see. And it really points to then where to act to lead to some of these. So one of the last examples that I want to talk about is now thinking about broad-based quality improvement measures. And so the example that I'll give is the patient-centered medical home. So patient-centered medical homes are a national model for primary care delivery that brings together a lot of different aspects of care that are have been shown to improve quality. So, for example, care coordination, team-based care, and so forth. The VA rolled out patient-centered medical homes nationwide starting in 2010. So the VA is spread over 1,000 sites of care. It was a massive undertaking to really transform quality in this evidence-based way. What we wondered is, does to use sort of a colloquial term that I've heard, does a rising tide lift all boats? In other words, when you improve quality, does that also improve equity? And so that's what we set out to do with this particular study. There are some reasons that patient-centered medical homes might reduce disparities. So all of the different components I mentioned that lead to better outcomes include team-based care, the focus on enhanced access, continuity, coordination, basically all of the different factors that we said were less likely to be present in some of the vulnerable patient populations that we serve. But conversely, there might be reasons that patient-centered medical homes might not reduce disparities. These constructs did not explicitly take on tackling disparities. And in fact, actually, the patient population is not distributed evenly across the VA. For example, most racial ethnic minorities using VA are concentrated in a small subset of VA facilities. I didn't talk about homeless experience veterans, but you might say the same thing. I practice in Los Angeles, and that is sort of ground zero in some ways for homeless experience veterans. And so we're looking at national data, but it's really, some things are really regional or site specific. And so what we found, we looked at, we conducted a pre-post difference in difference approach and looked at 2009, the year before the start of the rollout of the patient-centered medical home, to 2014, when we thought that most of the main features would be implemented. And we found a few different things. So the greater PACT, Patient-Aligned Care Team, is the acronym for patient-centered medical homes within the VA. And so PACT overall did what was intended to do. It improved the measures we looked at were hypertension and diabetes control. There are others who have looked broadly across different patient experience and quality measures, and it did improve those overall. Unfortunately, we found that racial and ethnic disparities present prior to this implementation persisted. There were a number of reasons for that. So some of the sites with higher percentage of minoritized racial and ethnic populations had lower PACT implementation. Why is that? Well, when you looked at what was happening, this was rolled out right after the economic downturn. It was rolled out in the midst of an access crisis. So the context over which this was being rolled out changed. And so once again, a greater strain on from these external forces on sites that may then sort of reverse some of the potential or neutralize some of the potential advances of this quality improvement. We also looked at patient factors, so residential neighborhood deprivation, and these were associated with worse chronic condition control. And so there are multi-levels at which some of these health outcomes develop, and that sort of accounted for some of the persistence and disparities by race and ethnicity that we identified. So what can we do about all of this? There are several actions that both healthcare providers as well as health systems can take. This is actually a quick snapshot of what providers believe in terms of where the responsibilities lie for reducing disparities. This was a VA study. So the VA health system, you can in this particular survey, pick multiple areas. And so VA healthcare system, 75%, VA providers, 69.7%, VA patients. So 69 or 70% of providers sort of endorsed that that's where the responsibility lies with us for addressing disparities in our patients. But here's sort of the blind side of that, healthcare's blind side. This is a study outside of the VA, so this applies to all of us, not just those practicing in the VA. This was a Robert Wood Johnson Foundation study that looked at primary care providers and pediatricians nationwide. 85% believe that unmet social needs are leading directly to worse health. So they've, understand that model. But 80%, the vast majority, did not feel confident in their capacity to meet patients' social needs and believes this impedes their ability to provide quality care. Fortunately, there are a number of different recommendations out there. The ones that I have on the next few slides are from the ACP. However, there are many different position papers as well as other types of tools and recommendations I've seen put out by other medical societies. So number one, the American College of Physicians recommends integrating education about social determinants of health and underlying systemic issues into medical education at all levels. The premise is that if we know about it, if we're knowledgeable about it and screening and approaches, that will then help us address some of these outcomes in our patients. Another recommendation, increase in screening and collection of social determinative health data. So none of the work that I presented today would be possible. We wouldn't know about these gaps if we didn't collect the data. The example that I have here, there are some pilot projects for how better to collect the data. So certainly patient self-identification of different characteristics, but there are a number of different tools out there for how to put this into practice. Looks like I skipped over slides for some reason. So some people say, well, is it legal? This particular cartoon, I love it. It's a baby. Federal regulations prohibit our mentioning its race, age, or gender. It's legal. Not only is it legal, but when you explain to patients why you're asking, then they appreciate, understand, and provide information. So increasing interprofessional communication and collaborative models that encourage a team-based approach. That was a question that came up when we were chatting a little bit before this talk, that really team-based models for delivering care help bring together not only different partners within the clinical team, but also social work and other groups that can help really problem solve effectively on all different aspects of care that need to be addressed. And then expanding the patient-centered medical home team to sort of the medical neighborhood. So that's an interdisciplinary team. And then using patient-centered communication skills such as shared decision-making. These are some examples: asking permission to discuss the topic, exploring patients' understandings, beliefs, really building trust, building understanding, and providing information as a way to help co-create plans of care that are acceptable. This is something that was studied explicitly with the COVID-19 vaccine acceptance studies. And then a whole health initiative. So whole health is an initiative actually championed across the VA, but also present elsewhere, that takes into consideration social aspects of patients' lives. Patients' values, their needs, their goals. It encourages patients and providers to develop a partnership to identify what matters most. We may see patients face-to-face 10 hours a year. The rest of the time, they're within sort of the context of the communities, their families, and what matters is maybe not necessarily clicking off that quality metric, but sort of what is underlying it, like what it means in terms of like pain, their ability to like get down on the floor and play with their grandchild or whatever. So finding out what matters and then linking it to care to help them meet their personalized goals. These are one of many snapshots of some evidence synthesis reports. These systematic reviews really brought together a snapshot of the different interventions. This one is focused on reducing racial and ethnic disparities. And this particular one is important for a couple of reasons. It sort of looked both broadly, both within and outside the VA, because one of the lessons is that what works in one health system often can be adapted and implemented and tailored to the patient populations in other systems. So some of the different advances I've mentioned are broadly applicable. The other main thing, they categorize interventions as either generic, meaning sort of a broad quality improvement intervention, such as implementing patient-centered medical homes, versus tailored to a specific patient population. And similar to the research that we found is that the most successful interventions were those that were tailored to specific populations, at least in reducing disparities. One of the examples is a peer support tailored intervention for addressing mean A1C, so glycosylated hemoglobin or diabetes control. This one looked at peer support, and it looked at different aspects of outcomes, assistance in daily management, social emotional support, linkage to clinical and community resources, and outgoing support. So a number of different ways in which peer support, community health workers, and other settings can really help to bring about change. And the control group in red, A1C went up. That's bad. Intervention group, you can see the magnitude over 6 months of decline in the A1C. So patient dashboards, interactive online tools within the VA Office of Health Equity website has tools that allow health systems to drill down to comparisons by demographic characteristics and different outcomes at their local level. VA has online patient dashboards that allow individual providers to drill down at their own level. So it's information at a level that's actionable, and then embedded programs to address some of these social determinants of health, such as food pantries, internet-enabled devices, so that broadband access isn't necessarily an impediment to access to care. I'll leave you with this last slide, just thinking about some of the implications, some of the other implications. So one, that under identifying some of the underlying determinants of persistent disparities and preventable outcome is key. Conducting ongoing monitoring. So if we don't measure it, we won't know that these gaps are there. And then using multiple metrics to track progress toward achieving both quality and equity goals, that you really need both. and reaching beyond the healthcare system to the community, incentivizing some of these, and then integrating strategies tailored to social determinants of health into quality improvement programs. So with that, I will stop for questions. Thank you so much for your attention.
Thank you very much, Dr. Washington, for your amazing presentation. That's so pertinent. I do have a question in the chat that I wanted to share. This is from Dr. Rosemary Adamson. The question is, Dr. Adamson wants to know about your thoughts on gaps identified in preventative care and what the causes of those gaps might be. And as an example, you illustrated previously that veterans of lower income are less likely to receive annual flu vaccinations. And have there been studies to try and identify why that may be? And I think you did touch on some of those potential reasons why in your presentation, but just any other comments you have of what might be driving those gaps in care?
Sure. Yeah. I'll give a twofold answer to that. So one example, you raised the example of flu shots. In some ways, flu shots are sort of a one and done in the sense that if the patient is there in front of you, then the access issue may not be at play. But there's the historical, not just the historical interactions with the healthcare system, but sort of the patient experience. So some of the slides that I showed some of the differences by patient characteristics such as race and ethnicity and socioeconomic status and patient experience of care. If you don't trust the provider, then you are less likely to accept some of the things that are recommendations that might be offered. So that's one. And then shifting to a different aspect of preventive care, colorectal cancer screening. So FIT test or fecal immunochemical tests certainly are an easier way to start the process. But for patients who require colonoscopies, then you can imagine many reasons that social determinants come into play. Some of my personally, when I think about my own patients, they discuss not having a place to do the prep, do the bowel prep. So if they're living in a situation with like shared bathroom space or otherwise, not having social support, you need someone to pick you up after the procedure. If you don't have that, then you can't get their procedure. And so there are a number of different social determinants of health, as well as we didn't talk about institutional bias or structural racism or some of the other factors that influence decision-making, but all of those really play out into the, oh no, I'll pass on the flu shot. One of the points of the talk today is really to really understand what's behind that. Okay, well, let me just check that off on the list and move on to the next question if you really want to get at helping improve uptake of some of these preventive factors. There's a question from the audience, yes? So the question and comment really came from one of our hospitalist colleagues, and she relayed the experience of admitting two patients who were walking barefoot in the snow, had gangrene and required amputations. These were homeless experienced patients who really had nowhere to go after hospital discharge. And the question is, maybe what we can do. the systems, a comment that really the systems aren't set up to help address some of these issues that we know lead to preventable morbidity such as gangrene and amputations. I think that it's really important for us in our roles as clinicians or as investigators to really step back and take a population health approach, thinking not about sort of that one patient in front of us, but the patient population that we're serving and what all of the, really the path that led them to us. So the homelessness that then led to the walking barefoot and so forth, and work within our different spheres of influence so that we can then use the research, use the case reports, use this information then to address whether it's public policy, addressing community factors and so forth. The other thing is the recognizing that we're trying to achieve the best outcomes possible for our patients. It's then to work with our health systems to incorporate within our health systems the types of resources that can begin to get at some of that. So preventive approach would be even screening our patient populations for that in advance so that we can then connect them with resources to try to prevent unstable housing. Others would be embedding social work and resources within the hospital system. I'm sure that's probably there, but really focusing more on the transitions of care, because what you didn't mention, but I'm sure that this is the next chapter of that story, is then sort of the wound care after hospital discharge and how that could lead to further adverse outcomes. And so really understanding that we're not just responsible for an isolated point in time, but thinking about like improving the health of the population and then developing strategies to do that. Another question. So the question relates to the funding structure for healthcare delivery, and that in a fee-for-service system, social workers, some of the other sort of agents of addressing social determinants of health are unreimbursed services. And the question is, how can we move toward either a different system or a different approach to being able to address that? So, boy, that's a complicated question. It's a hard issue to address, but I think there are a couple of strategies to begin with. So number one is when we think about how hospitals are reimbursed, that we should work to think about like the metrics, the outcomes, if and you know, this may be less relevant for fee-for-service, but recognizing that some of those supports, and so maybe this is more a capitated system that I'm describing, but recognizing that some of those supports then contribute to better outcomes, designing the studies, the cost-benefit studies that show that expending part of hospital expenses, let's say if it were reimbursement based on quality outcomes, spending some of those resources to enable addressing some of those social determinants of health would ultimately lead to better outcomes that could then translate to reimbursement. But it's changing the metrics. It's recognizing that greater resources are needed for populations that have greater challenges, so that the structure is set up to reimburse for that.
Well, thank you very, very much again, Dr. Washington, for that wonderful and thought-provoking presentation. We're over time, so we'll call it an end here. And thank you again, audience. And we'll see you back in about 2 weeks for our next grand rounds. Again, a big thank you to Dr. Washington. Take care, everybody.
Thank you. It's been great.